So, in this lecture we are going to discuss about the National Malaria Prevention Program Part 2. In this lecture we will discuss about the other programs which are for control of the malaria. Then we will discuss about the WHO data which is showing the malaria trends in our country. So, let us start. The overview of National Anti-Malaria Program. In the previous lecture, the part number 1, we have covered about the National Malaria Control Program which is launched in 1953, the very first program. And after that there is one another program in 1958, National Malaria Eradication Program. After that there is another event 1977, the implementation of MPO malaria, yes, modified plan of operation. So, these three programs we have covered in the previous lecture, part number 1, okay, where we have discussed about the objectives, means to reduce the number of malaria cases, to reduce the morbidity, to control the mortality, yes. So, these of the things we have covered in the objective part of these all programs, and then also we have covered about the API, annual parasitic index. Then we have also covered about some establishment under the malaria surveillance, like fever treatment depots and then drug distribution centers. In this lecture we will cover about some other programs which we have left, like 1996 there is one program, Malaria Action Program, yes. Then after that there is one event, another in 1997, which is the Enhanced Malaria Control Project, okay. Then in 2003 we have another program which is the integration of many of the vector diseases. So, the program has been renamed as National Vector Borne Disease Control Program, and the small of the aspect also we have covered in the previous lecture about the National Vector Borne Disease Control Program. So, let us start with the Malaria Action Program 1996. So, this program is launched due to occurrence of epidemic in some of the areas, okay. So, number of malaria cases rising so fast, okay, abruptly these cases rising. So, on the basis of this condition we have launched one Malaria Action Program in 1996. So, there is a one expert committee. It was formulated to identify the epidemiological parameters, means what are the causative factors, why the cases are rising in a particular area, yes. So, this expert committee is doing the surveys, they are identifying the epidemiological parameters, means what are the conditions, okay, what are the causes, and these are including many of the things, yes, means which is the plasmodium most seen plasmodium species, okay. Then what are the vectors we are identifying, yes, and which is the particular age group which is affected with the malaria, yes. So, these are not only these 3-4 points, but there are many other factors can also included in the epidemiological parameters for the high risk areas, yes. Then following areas were identified under Malaria Action Program. So, what are the problem area here? I told you this program was launched due to the occurrence of the cases in the areas, yes. So, the problem area we can see hardcore areas. So, the tribal areas where the facility is the people at those of the places are not able to access the facilities, okay, as the other areas can take. So, the hardcore areas or the tribal areas, okay, this is one of the problem area. To do the epidemiological survey at those of the area is also means it is one of the tasks, yes. Then epidemiological prone areas, yes, where the number of cases we have seen from many of the years, the past trends also showing the number of cases, those of the areas are epidemic prone areas, yes. The areas which are called the project areas, okay. So, means project areas we want to control the disease at particular area, or we want to eradicate the disease, we want to eliminate the disease at particular area, those areas under the project areas. Yes. Then triple insecticide resistant areas. So I told you in the first part of this program, malaria prevention program, there are insecticides we are using to control the malaria, like DDT, parathion, malathion. Yes. So these there are some areas which are resistant with those of the insecticides. So these areas also are the part of the problem area. Okay, so to control or manage, we have to strategize. Okay, we have to plan something different for those of the areas to control the malaria or to prevent the number of cases. Then urban areas, of course, because the urban areas, we have to plan the primary healthcare centers, secondary or tertiary healthcare centers, to provide the infrastructure at those levels also. So we have divided the areas into these of the parts. Yes. Then after the malaria action program, there is another program or project is launched, Enhanced Malaria Control Project. It is launched in 1997. Here the main role is of the World Bank. This World Bank provided support of and they have provided the funding. So they have supported project for 6 crore tribal population. Yes, I told you tribal areas are one of the part of the problem area. So they have provided 6 crore tribal population in 8 states. They have supported these peoples. From the 8 states has been implemented in nearly 1045 primary healthcare centers in 100 districts of 8 states, okay, which are the part of the problem area. Now selection criteria, how will decide, yes, this primary healthcare center should be covered in the enhanced malaria control project. So there are some factors which will speak, yes, this primary healthcare center could be the part of enhanced malaria control program. So the first here is, if the annual parasitic incidence is more than 2, okay, in last 3 years. So the trend of the last 3 years are showing that the number of cases are more than 2 per 1000 of the population under the surveillance. Okay, so this is first criteria. Second, if the Plasmodium falciparum cases are more than 30% of all the malaria cases. Okay, so all of the malaria cases means all of the species we are covering. From all of these species, the Plasmodium falciparum species, if it is more than 30%, then we'll put those of the primary healthcare centers under the enhanced malaria control project. Yes. Then after that, if the 25% of the population is from the tribal part, from the tribal area where the people are not able to access the facility, yes, at the time those of the PHCs will be covered in the EMCP. Yes, the area has been reporting deaths due to the malaria, and the areas, because the death we are saying here, why there is a death, of course they are not getting the diagnostic facility at initial level, they are not getting the treatment facility at initial level. Yes, so these are some of the reasons why we are putting the primary healthcare centers under the enhanced malaria control project. Now what are the objectives of enhanced malaria control project? So we want to reduce the disease, malaria disease, then we want to prevent the deaths due to the malaria, and we want to achieve all of the gains which will get by eliminating or reducing the transmission of malaria. Okay, so these are 3 objectives here. One is reduction, second is prevention of cases, and consolidation of the gains. Now see what are the important strategies of enhanced malaria control program. So how will implement it? Yes, means what is the basic infrastructure here? First, early case detection. Okay, so early case detection requires the testing facilities. There should be the testing kits for dipstick test. Okay, there should be a testing facility for optimal test. There should be a testing facility for blood smear examination. Staining facility should be there. So early case detection and prompt treatment. Okay, and when we'll get the results at the early detection by using of the instruments or equipments, then there is a need to treat. Okay, so for the treatment we need the drug supplies. That's why written the prompt treatment it is required. We want to cure the disease at initial level. Yes. Then link workers are required. These link workers are working at the ground level or fundamental level. So at least one link worker is required per 2000 of the population. Yes. There should be requirement of microscope because they are required to detect the malaria with the help of the blood smears we have prepared. So we'll see these of the blood smears under the microscope and detect yes, this is the particular species involved or the presence of malaria is there or not. Then dipstick test is a urine sample examination will do, and there is one strip we are using, and on the basis of the color change on this strip we are identifying yes, the protein is present or the glucose is present or some other component is present, yes, or which specific protein is present. So this dipstick test facility should be there. There should be fever treatment depots. Okay, so if any person is reporting fever and is suffering from chills and rigors, then the person can approach to those of the fever treatment depots where these persons will give the these blood smears and then evaluated under the microscope for the detection of malaria. If it is there, then there is a prompt treatment. Then selective vector control. Yes. So how will control the vector? I told you there are some type of fishes we are using, that is known as a larvivorous fishes. Okay, these fishes, what these fishes will do? These fishes will eat the larva of the vectors, these mosquitoes. Yes. Now there are some other strategies as well, like we can use some biocides. Okay, so these are the these biocides, what they are doing, there are some bacterias. Okay, example of bacteria here is the Bacillus thuringiensis. This bacteria it is killing the mosquito. Yes, and thus we are achieving the control of the malaria. Then residual spray in area with more than one case of Plasmodium falciparum. One thing also we can do is the insecticide sprays. Okay, like DDT, malathion, parathion, these type of insecticides are used when the case is reported at least more than one case of Plasmodium falciparum. Then there is a personal protection also can be used where the person they can use the bed nets, and these bed nets should be treated with insecticides. Yes. Now see, there is a one figure here we can see is the insecticides bed, in insecticide treated bed nets, and which insecticides we have used here is the delta methrin. Yes, so this is one of the insecticides which is used for the control of malaria. This has resulted in the significant decline in malaria incidence and annual parasitic index. Yes, so there are two things we can see here is the average decline in Anopheles mosquito density, and the another is the Culisine mosquito density. Yes, this Culisine is also responsible for spreading the malaria, and not only the malaria, this is causing other diseases, means this is a vector for other diseases as well, the spread of other diseases. So by using of these of the insecticide treated bed nets, we have achieved at least here 68% decrease, average decline in these mosquitoes, Anopheles mosquitoes, and 50% decline we have seen in Culisine mosquito density. Then the chemicals which are used in insecticide treated bed nets. So the first we have seen is the delta methrin, Apart from it, we have cyfluthrin and some other insecticides such as permethrin, lambda cyhalothrin, etofenprox, cypermethrin. Okay. Their concentration we have written here, like for the deltamethrin, we require 2.5% of dosage of 25 mg per meter square area. Yes, whereas cyflothrin is required at least 5% here for dosage of 50 mg per meter square area. Yes. Now, effectiveness of pyrethroids, they are under the pyrethroids, all of these, yes, like deltamethrin, cyflothrin and other insecticides we have seen, they are under pyrethroids category. So, effectiveness of pyrethroids is for 6 to 12 months, okay, and they require the retreatment every 6 months. So, means at the interval of 6 months they require the retreatment of insecticides to impregnate it in the bed nets. Now, what is the long lasting insecticidal mosquito nets, means how many times we can wash them. So, also these long lasting insecticidal mosquito bed nets, they use the pyrethroids insecticides because they are very effective, and we can retreat them as well, and the chemical binder that allows the nets to be washed more than 20 times. Okay. So, this is very good thing here is we can wash them for more than 20 times, okay, allowing use for more than 3 years. Okay. So, this is, that's why we are saying it as long lasting insecticidal mosquito nets, because we can use it more than 3 years. Yes. Household bed nets used for mosquito control. So, there is some standardized value, like how many holes should be there in the bed nets and what should be the diameter of each hole, so that the mosquito will not come enter those of the mosquito nets. Okay. So, number of holes per square inch is more than 150. Okay. So, for per inch area we have put like there should be more than 150 space number of holes are there, and the diameter of each of the holes should be less than 0.0475 inch. Okay. So, this is one of the standard value for the household bed nets. Now, what are the common insect repellents? There are some sprays also available in the market. So, what are those of the common insect repellents? See, one is the DEET. Okay. Here is the NN diethyl M toluamide, then erythrine. Essential oil of lemon eucalyptus is also used, icaridine or picaridine, then nepetalactone, which is also known as catnip oil, citronella oil is also used, permethrin we have already covered, soya bean and neem oil also has the ability to repel the insects. Then see what are the resistant cases seen in the malaria patients. There are basically 3 types of the resistance. Okay. And we have divided it as R1, R2 and R3. Now, what are these type of resistance? So, see, start with the R1 resistance. Okay. In R1 resistance, what happened? There is a recurrence of infection between 7 to 28 days of treatment, completion following initial resolution of symptoms and parasite clearance. Okay. If any person is approaching with the symptoms and we have identified the person is suffering from the malaria, okay, means we have diagnosed it. So, we are assured with the diagnosis and we have started the treatment. So, what will happen in the R1 resistance is there is the revive of infection. Okay. Again we will see the infection, means the recurrence of the infection between 7 to 28 days of the treatment. The person is or the patient is getting the treatment and we will see the patient is suffering from infection again after 7 to 28 days of treatment. Yes, this is known as R1 resistance. Okay, initially we'll see what we'll see. We'll see the patient will be all okay with the symptoms, get rid with the symptoms. Yes, the parasite is not present in the blood, but after the 7 to 28 days of the treatment, we'll see there is again another infection. We'll see, or that is of malaria, and that infection is seen in the patient. Okay, so this is R1. Then what is R2? See, patients with marked reduction of parasitemia. Okay, so the level of parasites, when the patient will get the treatment, the levels of parasite will go down. Okay, and this should be actually happen with the treatment. Okay, so this is the normal thing which will go. So there will be marked reduction of parasitemia. So parasite count reduced by more than 75% at 48 hours. So means within a 2 days of the treatment, there is a marked decline of the parasites in the blood. But what happened? But fail to clear parasites by day 7. But in the duration of the 7 days of the treatment, the parasites level will not decline to, means they will not cleared from the blood. So this is known as R2 resistance. So treatment is not effective. Yes. The third is R3 resistance. What do you mean by R3 resistance here? Patients whose parasitemia did not fall by more than 75%. Okay. So the levels of the parasites present in the blood, they will not go down by more than 75% within 48 hours, but occasionally increased by 7 days. What will happen here? This thing you will see here, it will increased by 7th day. It will not decrease, it will increased by 7th day of the treatment. Okay, so these type of resistance we have seen in the patient treated with the therapy. Okay, in malaria patients, R1, R2 and R3. Now there is one program, National Vector-Borne Disease Control Program. This is the integrated program in 2003 to 2004. There was one program which is launched by merging some of the other diseases which are vector borne. So see, it is launched in 2003-2004 by merging National Anti-Malaria Control Program, National Filaria Control Program, which is causing filariasis. Yes, there is one disease, vector borne disease. Then Kala Azar disease. Okay, Kala Azar Control Program is merged. Japanese bee encephalitis, this is also vector borne disease. And dengue hemorrhagic fever, dengue or dengue hemorrhagic fever has also been included in this program. Okay, so there is a merge of all of these programs like filaria, we have Kala Azar, Japanese bee encephalitis, dengue, all of these programs merge with the malaria. Okay, malaria prevention program, malaria control program. And who is the directorate of National Anti-Malaria Program here? Is the nodal agency for prevention and control of major vector borne diseases. Now WHO World Malaria Report 2020. Okay, so this is one of the report which is showing the trend of malaria in India, where the India actually lies. So see, India continues to make impressive gains in reduction of malaria burden. So the programs what we have launched, we have achieved from them. Yes, so we have reduced the burden of malaria cases. Now India, the only high epidemic country, and we all know that India is an epidemic country with malaria. Okay, so every time we have seen the number of cases in some parts of the country. So it is an endemic country which has reported a decline of 17.6% in 2019 over 2018. So this is value, declining value. We are with this declining value in 2019. Yes. Now India has sustained annual parasitic incidence of less than 1 since 2012. So this is also one of the achievement for the India, that our API value is less than 1. Okay. Now what are the other values for India, according to WHO World data, so India achieved a reduction of 83.34% in malaria morbidity. Yes, means the number of malaria cases, and 92% in malaria mortality. Okay, means the number of malaria deaths between the year 2000 to 2019. Yes, so we'll see here the graph 2000 to 2019, and we can see the decline here. Yes, there is an increase in nearly to this year, can see 2004 or 5, and then we'll see the decline in the deaths. This graph is showing that there is a decline in the number of deaths of the malaria in these of the coming years, and 2019 we have declined it up to 92% of decline of 92% in malaria mortality. Yes, thereby we have achieved the goal number 6 of Millennium Development Goals. So there are some goals under MDGs, Millennium Development Goal, and if you will see the goal number 6 of MDG, Millennium Development Goals. So in that goal, what is there? There is a combat, means how to reduce the HIV disease or to malaria or some vector borne diseases. So we have achieved here in the goal number 6 Millennium Development Goals, and we have reduced the malaria cases or deaths. Okay. Ultimately, we will say on the conclusion basis 50 to 75% decrease in case incidence between 2000 to 2019. This is a very good achievement, means how our programs are working so good. Yes. Thank you so much everyone. I hope this is clear to all of you about malaria prevention program. So we'll meet in the next session with the next